Hello, everyone, and welcome. Good afternoon. I'm super excited to welcome you all back for our first session of this year of 2026 for our Hispanic Serving Institution webinar series, also known as Centering Servingness. My name is Carla Silva, and I am the Director for HSI Initiatives here at the University of Arizona, and I'm really excited to have you all join us today to hear a little bit more about some of the work that's happening here specifically. But before we get started, we always like to begin by recognizing and paying honor to the original inhabitants of the land on which the U of A resides on. So the region that we live in and here at the U of A includes the ancestral homelands of the Tohono O'odham Nation and the Pasquayaqui tribe. We offer our gratitude in being able to share knowledge on these indigenous lands. I also invite you. I see that some folks are joining us from different parts outside of Tucson. If you know the lands that you inhabit or that your institution might reside on, we always invite you to also share that in our chat. And then just a little bit more about our webinar series. So this webinar series has been around for about 5 years now and has been informed by Dr. Gina Garcia's extensive body of work on the concept of servingness, as you see in her title. So this webinar and each year we feature different faculty and staff, both here at the U of A and outside of the institution. So whether community partners or folks from other institutions in Arizona or even outside of our state. And really, we want to show the different scholarships, programs, initiatives, and different servingness efforts that honor the cultures and lived experience of our students, staff, and faculty that we are serving. So the goal of the series are in 3 parts. So one, to spotlight current scholarships. So again, offering those examples of rich ways in which servingness is enacted by faculty and staff across institutions. 2, we are always inviting others, right? So again, both on campus or in our state or even nationally to learn about and engage in these efforts. And then lastly, to build knowledge. So again, each month we invite folks, right, to share about the work that they're doing, because it might be something that you're interested in bringing to your area or to your campus, or it might help you, right, think through a challenge or think of better ways to serve the folks that you are serving. And then just a little background about the U of A. So we have been in HSI since April of 2018. We were the first four-year public university in the state of Arizona to be recognized as an HSI. We have also been recognized 3 times with the Seal of Excelencia, which is an award given by Excelencia in Education that really recognizes the U of A as an institution that's demonstrating that intentional impact and success towards our students, Latino, Latina, Latinx, and other underrepresented populations. So again, I'm super honored that you all took some time out of your day to join us here. As always, this will be recorded. So if you have a colleague or know of someone who might be interested, once that recording is out, it'll be all over social media. So we encourage you to share that out. So I'm really excited today to introduce some folks here from the University of Arizona College of Medicine who will be talking a little bit more about the work that they are doing. So I'm going to go ahead and introduce our 3 facilitators today. So you will be hearing from Dr. Celia Valenzuela, Dr. Jose Munoz Jr., and Dr. Alejandra Zapien-Hidalgo. And so they'll talk for a little bit, 40 to 45 minutes, and then at the end of that, we'll open it up for Q&A. But we also know that you might have questions during their presentation, so feel free to be dropping them in the chat or in the Q&A, and we'll definitely be able to get to them at the end. So I'm going to go ahead and pass it on to our facilitators.
Thank you, Carla, and thank you so much for the invitation to present here. My name is Celia Valenzuela. I am the Vice Dean for Community Engagement and Partnerships at the College of Medicine here at the University of Arizona in Tucson. And I also am an OBGYN by training. I've been on the faculty for going on 17 years, and I've been in my Vice Dean role for approximately 3 years. I'm going to pause there to allow our other panelists to introduce themselves as well.
Hi, everyone. Buenas tardes. My name is Jose Munoz. Pronouns he, him, él. And Dr. Sylvia, thank you so much for the warm introduction. And just an honor to be here. I've been in higher ed practitioner for the past 15 years, and I've been here at the University of Arizona College of Medicine, Tucson for the past 3 years. So thank you all so much for joining us.
Buenas tardes. I'm Alejandra Zapien-Hidalgo, assistant professor at the Family Community Medicine and also a bilingual director of the bilingual health, my medical Spanish distinction tracks. I've been here at the university for almost 15 years and so happy to be here. And I hope you learn a lot from what we have to present today.
Thank you. We thought it would be a good idea to get started just with some groundwork in terms of why is this important. I wanted to share this slide that depicts a graphic that I obtained from the American Association of Cancer Research. This was a report that was published in 2024. I love this graphic because it really ties in the different factors that contribute to inequalities in health outcomes. So we say that there are environmental factors, where we live. Are we able to, do we live in a safe neighborhood where we can walk around and exercise? Or what's the air like that we're breathing? There are behavioral factors in terms of what we consume and our level of activity, clinical factors like are we able to access healthcare? What sort of quality healthcare is available to us? Biological and genetic factors. We know that there are certain groups that are predisposed to having certain illnesses, genetically speaking. And we know that there are psychological factors. Stress has a large impact on mental health, which can impact our health overall. And of course, there are cultural factors. And what we're going to really focus on is something that is a large social factor that contributes or can contribute to inequalities in health outcomes. Next slide, please. Before I go into speaking about language, I just want to point out that there are a number of chronic illnesses that we see more commonly in certain populations, including Hispanics, such as diabetes, heart disease, increased risk of stroke, dementia, that sort of thing. And there are things that can contribute socially. So here's one of those examples. We know that Hispanics have a higher percentage or likelihood of not having insurance. So this graph depicts a percentage of people without health insurance in the United States from 2010 to 2023. And I'll remind you that 2010 is when subsidies were first available through the Affordable Care Act. So we can see that those subsidies allowed the percentage of people that were uninsured to go down, but Hispanics still stayed the highest. I am very concerned now that subsidies are no longer available. These numbers are very likely to trend back upward. Next slide. We also know that, so this is a graph that depicts the number of individuals over the age of 25 in the United States who have graduated from high school by race and ethnicity. The lowest line, the gray line, are Hispanic individuals. So Hispanics are less likely or have a higher percentage of individuals that have not completed high school. And it's not because Hispanics are lazy or because Hispanics are not smart. There are a number of factors that contribute to individuals' ability to complete high school, but that also then impacts our ability to get a well-paying job and get insurance and that sort of thing. Next slide. When we look at data in terms of poverty rate, actually, I'll take a step back and say when we look at data in terms of in a family, whether or not there is an adult that's working, that data tells us that Hispanics have the same number as other groups in terms of individuals or families that have an adult that's working. And yet, Hispanics have a higher rate of poverty than some other groups. We also see that individuals who are Black and individuals who are American Indian or Alaska Native are more likely to live in poverty or under the poverty rate in the United States. Next slide. One other factor, and this is what we are going to focus on today, is whether or not the physician speaks the same language as the patient that they're caring for. Here's one example. Here's a study that showed us that language concordance really impacts health outcomes. So this study looked at individuals who were Hispanic, or Spanish speaking only, who had cancer, and half of them were assigned to see a bilingual physician who spoke to them in their native language, and the other half saw a physician who spoke to them in English using a professional interpreter. Then those patients were asked to complete a validated questionnaire. So they were asked things like, how satisfied were you with the care that you received? And that study showed us that patients who had a provider who spoke to them in Spanish, they perceived that person as more empathetic. They were more confident in their skills. And most importantly to me, they perceived the opportunity to be able to disclose information higher. They looked at what they called the number of utterances, the number of times that the patient spoke outside of being asked a question, and they were more likely to speak, that those utterances were higher when they had a Spanish-speaking physician. I'm going to go to the next slide, please. This is a figure from that study, and this figure is looking at the percentage of patients who the evaluation was on a scale of 1 to 5, with 5 being the highest score that you can give. And they looked at what percentage of those patients scored 5 out of 5 for the different parameters that you're looking at there, such as general satisfaction, communication. And we see that a significantly higher number of individuals who were spoken to in their native language of Spanish, depicted in yellow here, rated these different categories as 5 out of 5. I'm going to pass it on now to Dr. Munoz, who's going to share a little bit more about why Spanish, or language concordance rather, is important.
Thank you so much, Dr. Valenzuela. So just to continue to paint the picture of the importance, the importance and the impact of language concordance on health outcomes. Here is a literature review that really documents the impact that language concordance has. And about 25 out of 33 studies, which about 76% of them showed at least one improved outcome when it came to patients that received care in their preferred non-English language. And when language is shared, patients report greater satisfaction and stronger communication, to what Dr. Valenzuela was presenting in the earlier slide. And this helps patients feel better. They are more engaged in their care and are more likely to ask questions to their provider and participate in decision makings. And this benefits goes beyond just the perception, but studies show improved clinical outcomes, better medication adherence, fewer emergency room visits, especially when it comes to chronic disease management. And I think perhaps one of the most important things in language concordance, it just leads to fewer communication errors and reduces misunderstanding and just strengthens the alliance and improves safety. And language concordance doesn't just make someone feel better, but it works better, and it's very well documented. Anecdotally, I'll add my dad is a Spanish speaker. In the past few years, he has been dealing with health issues, and I accompanied him to the doctor, to different appointments, and I've done my own anecdotal research, and I asked my dad the differences that he when he's talking to an interpreter compared to a physician that's is Spanish speaking, and he often aligns very well with a lot of what the studies show here. So there's just a little side story that I like to share, and to again to reemphasize the importance of health outcomes when it comes to language accordance. So and here at CompT, preparing our future physicians is important, and we are always constantly thinking on how we're preparing them to meet the community needs. And it really starts in how we're training them. both didactic and on the clinic side. So medical education always continues to evolve and be responsive to the realities of the patient population that we serve. I think specifically here at ComT, where we are, we're who we are as a university, land grant, Hispanic serving institution. These are not just the theories, but also like as a college, how do we put these in practice? And our as our community becomes more diverse, multilingual, and shaped by structural inequities that Dr. Valenzuela was highlighting at the start, our training must be, our training must prepare them to meet these physicians. So they can meet those realities head on. And these skills don't happen intentionally, and through various opportunities to serve underserved communities, and cannot be optimal or informal. So setting up structures such as what has been such as the Spanish language bilingual distinction tracks to be taught and assessed and help sustain across the continuum of medical education from our medical students to our residents. And this includes key competencies such as addressing inequalities in health outcomes, preparing them to be culturally responsive to their patients, talking about social determinants of health, and understanding our own self as a physician and our own biases that we show up when is important as well. So these skills are embedded throughout our medical school here, and we don't just try to improve cultural competencies, but address how we as a school, as medical school, we can help them be culturally responsive with the improvement of quality, safety, and equitable care. And this is how we have gone in creating a lot of our educational materials, programs, distinction tracks, and other opportunities where our medical students get to serve. So to continue looking at the bigger national picture, and there is a gap that becomes really clear specifically to our Hispanic and Latino population. About 19% of that U.S. population it identifies as Hispanic and Latino, and nearly 70% of those, which is about 42 million, speak Spanish at home. And for many of those, this is their primary language, used in moments when they go visit a doctor, when they go to do decision making and care. But yet, I think only 6% of physicians identify as Hispanic Latino, and just 2% of those are non-Hispanic physicians and are Spanish speaking. So here you can see the big gap that exists and the how it can affect communication, safety, and trust and health outcomes given our Hispanic Latino population. And this is not just, I think, a workforce issue. I think it talks to a bigger picture on how we're preparing and delivering high quality care as we train our physicians to be better equipped to serve these realities of the communities we get to serve today. To narrow it down and look at our state of Arizona and why language matters and language concordance is important. Here in Arizona, Arizona ranks sixth in the U.S. for households where Spanish is spoken, and nearly 21% of those residents speak Spanish at home, and over 32% of those identify as Hispanic or Latino, Latinx. So it continues to make the case of kind of this program that we're about to share. And more narrowly here in Tucson, the numbers are even higher. About 26% of residents age 5 and older speak Spanish at home, and roughly 43% of the population identifies themselves as Hispanic or Latino, Latinx. So I think these figures just show for many, like, English is not, it could be a language that they're often not comfortable or can't build trust or clarity, especially in moments of sickness. So patients can't fully express their symptoms sometimes, can misunderstand diagnosis, and just takes a little bit more trust for them to be heard, for the quality to be care, and it could create more wider disparity. So for our college, it's important to think of these, and again, as the institution, like where we stand in a border region like ours, this data is important in how we prepare our physicians, not just beyond like interpretation, but giving our medical students the opportunity to participate in a program like our Spanish bilingual Spanish distinction track. So I think these demographics really capture how we are moving that forward in preparing our physicians. And then why does this matter overall is because I think our U.S. medical education, as I mentioned earlier, has been shaped, continues to be shaped to the realities, and many of these realities are also shaped by students and faculty who are willing to lead and advocate for change, to not continue to be a to not just accept the status quo, but adapt programs, policies to learners and educators to ask the questions of how we're preparing our future physician workforce. And this doesn't just happen by representation alone. The increase of number of Latino, Hispanic, or Spanish origin physicians is critical. As I mentioned before, about 6% of our physician workforce identifies as Hispanic, Latino, but that representation has to be paired with intentional like training and institutional support and accountability from medical education. So this preparation matters, and then here at CompT, so grateful to have a Dr. Zapien, who leads a lot of our Spanish distinction track, both on the medical school and GME sides, to address some of these skills and cultural humility, and helping our learners understand structural understanding of the Latino Hispanics community effectively. So this is important, and just super proud to pass it on to Dr. Zapien, who has been leading and instructing many of these distinction tracks that we're about to share with you all. So I'll pass it on to Dr. Zapien. Next.
Thank you, Dr. Munoz. So today I'm going to be talking about just two of the programs that we have. One is the Medical Spanish Distinction Track that is offered to medical students, and the other one is for residents. So before getting into the programs, something that came to mind, and we should probably add it to our slides. Looking at the number of the population that speaks Spanish, when they fill out the survey by the census, when they choose or check the box saying that they speak other language at home other than English at home, they need to select what language they speak at home, and then they say Spanish. And then the next question that pops up is, how well do you speak English? So based on those answers is how the federal government identifies, and the term they use is limited English proficiency if these patients select below well or not at all. So the percentage of the population, it goes up and down a little bit, but it's around 8% of the US population. So for this population, we either need to prepare bilingual healthcare providers or have interpretation or language services available when they go and seek care. Now, we don't want, or we, in the academic setting, we don't like to use that term, LEP. We want to change or shift to non-English language preference. So in this case, the patients go fill out the intake form and they need to choose their preferred language. I don't know if you were aware of the executive order that was signed in March, stipulating that English was going to be the official language of the US. I don't know if you're aware of the repercussions of this, but the federal government used to have a website. It was called lep.gov. And in that website, you could go and get resources. And so now the website is down. They have a message that they're adapting to the changes. The executive order was signed in March. In July, they shut down the website. So why is this important? If we look at how we're going to prepare our students, it is important because as part of the language in the executive order, if we go a little bit back and look at the law behind language services, hospitals or clinics that were getting federal money, they were obligated or mandated to offer those services. Now, with this new executive order, that can change. They don't know how, but that can change. So with that in mind, this is something that I talk to the students in Phoenix. I also have the program in the College of Medicine Phoenix, and now puts more weight on our students to get prepared once they go out, once they go and start working with the community. Maybe they're not going to have the same opportunities to have an interpreter, but now they are prepared. They are certified as a bilingual healthcare providers, and they can take care of our community. So with that in mind, if I can look at the next slide, please. So as I mentioned, I joined the U of A in 2009, and we started working with the, it was an elective, bilingual medical Spanish. It was an elective. And as many of these programs, you need to have all the factors. One are the students' interest, also the leadership support, and also having a faculty that can lead these programs. So at the beginning, it was just an elective, 1 semester long. But in 2015, we worked on creating a curriculum as a longitudinal program. So if we can, I can look at the next slide, please. So we created this new curriculum, and the goal is to work with students that already have Spanish, because I'm not a Spanish teacher or a professor. My background is in medicine. This beautiful accent is from Mexico. I was born and raised. I went to medical school in Mexico, and later on I moved to Tucson. So my background and my talents are medicine and Spanish. So it's how I work with students that their Spanish is intermediate, high, and advanced and above. Uh, and we're going to talk more a little bit later about that. But the goal of this program is to get them trained to the point to get certified so they can work with our patients. This can happen when they end or finish their preclinical years or the second year, or it can either be on the third or fourth year or later on. As you're going to see, we have the GME program also offering the same opportunities. Next one, please. So this is us. This is one of the, the groups. As I mentioned, it's a longitudinal program, which means we work with them for the 4 years in different capacities. This is under the Office of Community Engagement and Partnerships under Dr. Valenzuela. And the students that we recruit is students that have a high proficiency, Spanish proficiency level. And we have there the acronym ACTFL. These distinctions are based on the American Council for Teaching Foreign Languages. I got trained to do it. So when I open or invite the students to join the program, we do a Spanish assessment before joining the program. We learned that that was important, and I'm going to get into that later on. At the end of this program, the goal is for them to get certified as a bilingual healthcare providers, not as medical interpreters. And a little bit of what we do a weekly 1-hour class. Yeah, we're going to look, the next slide, please, where we're going to look at all the instructional activities later. So some people think about, oh, they're going to be learning medical terminology. No. What we're working on and what we work with the students is for them to be able to communicate with their patients. So we usually stay away from medical jargon, and we try to work with them to explain instead of just giving those big words to the patients. So we work in different areas, since like doing the medical interview, maybe explaining some of the diagnostic methods and sometimes the plan, but we move little by little during this 12 to 18 month long program. Next one, please. So just to give you an idea how many students are part of the program, in 2015, we welcomed class of 2019. And to be honest, I don't know who's the audience today. I don't know how interested you are in maybe recreating a program like this. I'm focusing today on a program in Spanish, but we also should start thinking about maybe creating a similar program, but in different languages. A language that is, I don't know, very permanent in predominantly in your area. Like I was reading about the program in Harvard. They started in 1990s and 2000s, and they had 4 different languages. They offer Mandarin, which is the #1 language spoken other than English here in the US. They also had French Creole, they had Portuguese, and they offer Spanish. as I mentioned before, how you can create these programs, you need three parts. You need the student interest, you need the leadership support, but also a faculty that can lead those courses. So going back to when we started in 2019, we did our lead review, how to create these programs. Number one, we needed to recruit students that had a high, it can be intermediate, high level and above. And we had really good response that we accepted students with intermediate mid, a lower proficiency, Spanish proficiency. And we divided the group into intermediate and advanced, meeting more often with intermediates and meeting like twice a month with advanced. That didn't work. The students with a lower Spanish proficiency, they dropped at the maybe half or at the end of the year because it was difficult for them to keep up with the class. And we kind of, the advanced level were like, hey, we want more. We needed more classes. So since 2016, we just have one group and we move together. And when I have a student that applies and has a lower Spanish proficiency level, I'm clear with them and say, hey, you're probably going to drop at the maybe midterm or at the end of the year, but that's something that I expect them to do because it's at that level is difficult to keep up with the class. As Dr. Munoz mentioned, the demographics, the College of Medicine, the first class, the number of Hispanic Latinos that were enrolled that year, it was around 11% of Hispanic Latinos enrolled at the College of Medicine. And we got half of that group participating in our class. The rest, because we look at the AMCAS application and all that, most of them didn't have like race, was not reported, but at least we got like half of Hispanic Latinos were enrolling in our program. We have really good numbers. A lot of the initiatives that the College of Medicine is doing we're seeing better recruitment of Hispanic Latinos and diversity in general. So we can see that the numbers of students currently enrolled in our program is a good representation of the class. The class usually has 110 students per class. Next one, please. So these are the structural activities. As I mentioned before, we meet once a week for 1 hour. We also require 50 hours of volunteering. At the College of Medicine, they have a program called COP clinics. So as part of those COP clinics, which is committed to underserved, they host a clinic, one different clinic per day, and they created a job where it's called interpreter. That, thinking back, is not a good representation of the work that our students do because I'm not training them to be interpreters. That's a different career. That is what they have. It's a way for them to differentiate and say, oh, they're bilingual. And some of the sessions, the College of Medicine right now has a club, a Spanish club. This year I haven't done the cafecitos, but I was doing a lunch hour once a month to just gather with all different Spanish proficiency levels. And it was more informal conversations, talking mostly about cultural issues. The students work on with standardized patients. So we work with the instructional skills clinic. So when we started the program, we recruited, and this is also an invitation if you know someone that is a Spanish speaker or is bilingual in Spanish and wants to join this group, I welcome you to come and reach out to them and join the group. Currently we have 5 standardized patients that work with our students. It's intensive. This program is very intensive. Like the preclinical years, the first and second year, and by the third and fourth year, we invite them to do an elective, either in Sierra Vista, Nogales, Yuma. The electives are for 4 weeks. We also ask them to take the certification test, which is a third party. It's done by Alta Languages, and we're going to talk a little bit more later. And they also, because the students, they don't do this for credit. At the end of the third, fourth year, they can take a class, a course, an elective course, and they can get credit for the work they did with the distinction track. Next one, please. So this is just the numbers. No, we had 170 students joining our program. 60 of the students passed the ALTA test. This means they got certified as a bilingual healthcare providers. And we have 69 students that haven't taken the test. They're MS1, MS2, no, they're MS2, MS3 right now. So waiting on them to take the test. Why they don't take it? The pressure, they have boards to take, they don't have time, they have clinics. So we need to do more, motivation for them to take it. So this just the numbers of our students taking that certification test. The next one, please. So we have the distinction track that is offered to residents. So the focus on these two programs is oral proficiency. So how they communicate. We don't review grammar, how they write, how they read. It's mostly like oral communication. For medical students, it's a little bit slow because they are learning medicine in English, and the goal is for them to first learn that and then teach the Spanish side. So with GME, this program is offered to residents that are working on the different specialties. So we have students or residents participating in the family community medicine residency program, surgery, OBG. So we get residents from all the different specialties. Next one, please. So again, these are physicians that they also, when they join the program, they need to take the assessment. And if it's intermediate, high, and above, they're welcome to join the program. And the goal, again, is to get certified. The certification works for us right now because it's a banner. It recognizes the certification, and they can get a body badge that says bilingual. Next one, please. So what we do is we meet once a month. Again, the residents don't have a lot of time, but a lot of them are very motivated. So we meet once a month. Right now we're working on having the opportunity to volunteer in local clinics. They also have a component that is healthcare advancement forums. They need to attend, and they work on a reflection paper. After they participate, we ask them to do it at least twice a year. Again, they get certified, and at the end, they get a certificate of completion. Next one, please. So these are the numbers of residents, again, from all over, all different specialties. Right now, and just skim over the list of students. 9 have taken the test, and 6 became certified, and that was the past 2 years. So those numbers are going to continue growing. Next one, please. So to keep in mind after this presentation, as I mentioned before, this is a program like this. It can represent each institution. Like right now, we're looking at just medical Spanish. Years ago, we had a student wanted to have Navajo language. So what was the issue? We didn't have a faculty to lead that initiative. So something that can help us is to conduct a needs assessment and recognize what languages are present. And the key of this is to identify and engage key collaborators. So the next one, please. So probably you heard a lot about this, but medical Spanish education is one of the newest fields in medical education. And also at the undergrad level, we have language for healthcare purposes, which is like a branch of language for specific purposes. So if you look at the Spanish and Portuguese department, they're going to have a section that is for language for specific purposes. And now we have the language for healthcare purposes. So those are new fields that we need to do more research to better help and support our students. Next one, please. So if you're thinking on creating a program like this, I will recommend this book. I had the opportunity to co-author one of the chapters, and it's a very important book for you to review before starting a program like this. For me, the most important part is language proficiency. And you can utilize, there are the 3 most important frameworks, which is the American Council for Teaching Foreign Languages. And you need to look at students having intermediate high and above. If you use the Interagency Language Roundtable, ILR, specifically for healthcare, the students need to have FAIR 2. And this is a framework that the American medical schools utilize when the students are filling out the application to medical school. They ask about if they speak another language, and then they ask for self-assess their level. So that's something that is already out there. And the other one is the Common European Framework of Reference for Languages. And this one, I use this one for one of the classes in Phoenix. It's a self-assess. And what they recommend is to have a level of B1. Another way to assess some of the courses, they utilize the CCLA assessment, which is the one that we use to certify, but some of the programs utilize that one as a pre and post assessment. So that's possible. Next one, please. So designing curriculum, if we're focusing on medical school, the best way to do it is organ system. Obviously, we need to go over the medical interviewing. Here in Tucson, there's one way to do it. In Phoenix, they have the doctoring program. So just adapting to what the colleges already have in terms of medical interviewing, and also how to work with the clinical skills, meaning working with standardized patients. Also going with the most common diseases. The best part, once we have this, the students, they have it done and they know how to do it. Now we move to how to explain medical diagnosis and assessment, and then how to explain treatment. As part of all this, the College of Medicine in Tucson already has um, a embedded in their curriculum to talk about health disparities. So we don't have that added to the distinction track because the students already are getting that information through the College of Medicine. Next one, please. And I'm telling you this very like, oh yes, let's do this. But we worked to standardize this curriculum, and it was just published in 2020. How to standardize these trainings. So it's something new. It's something that some of faculty are starting working on. But as I mentioned before, there's a lot of research that needs to be done to improve these areas. So the most important part of all the courses is how do you assess, and in this case, how to certify. So assessments, as I mentioned, uh, we have the CCLA by Alta Languages, is some of the clinics and hospitals. They also need to do the national standards, the class standards, national standards for culturally and linguistically appropriate services in health and healthcare. And this is a training for physicians and staff to better treat our patients. And they have different areas that they work on. So that's one of the trainings they need to do, and also to get certified. So for physicians, we need to do the CCLA, and for staff like nurses or the staff that works with the patients, they have the qualified bilingual staff. It's an assessment also by Alta. And recently, I'm part of the National Association of Medical Spanish, and with them we work on creating a new certification that better reflects the proficiency of our students or our physicians, because this is a certification that is done with a SP patient. So it's validated. It's a better representation of the Spanish proficiency of our students and physicians. So if you need more information, I can share it with you. Next one, please. So as I mentioned before, we cannot do this work by ourselves. We need to collaborate, and the major one for us is National Association of Medical Spanish, NAMS. I was part of the co-founders of this organization. We met for the first time in 2018. We created a task force in 2019, and we moved to a non-profit organization in 2021. So little by little, we've been growing, getting more members, and pushing more towards getting more information, more research. And the most important part for us was to create that evaluation tool, which is now Polum. We cannot do this without the help of the College of Medicine Tucson, having working with the COP clinics where the students can go and do their clinical rotations, and the Interprofessional Clinical and Professional Skills Center for supporting us, for looking for the standardized bilingual, standardized patients, and working with us to train them and to later work with our medical students and also residents. Another key partner is Clínica Amistad. Clínica Amistad is a free clinic in South Tucson, and they open their doors to our students to do their clinical rotations in there. We're gonna be sending. We send pre-health students. They also open their doors for medical students, and more upcoming the residents too. Next one, please. So just the key points, we know language has been identified as a major contributor to health disparities. It's considered one of the social, one of the most important for patients who prefer language besides English. we know that if these patients cannot communicate, we're going to have an increased risk of medical errors and poor outcomes. We know that the physician-patient language concordance is associated with improved quality in health, care delivery in health outcomes. And what we want to keep in mind is there are curricular opportunities to align language learning longitudinally across courses and clerkships, in this case with our undergraduates and graduate medical education. And with that, I think we're open for questions, concerns, ideas, ways to collaborate with us.
If anyone does have questions, we do have the chat and the Q&A feature open. I do also recognize that we are coming close to time, so I will do one question that we love to ask the folks who always jump on these webinars with us. And so for all of you, or for either one of you, we have kind of an overarching question that we tend to ask our facilitators. So I'm going to share that question with you all, and then again, whoever wants to answer, if you all want to throw a little tidbit. But thinking about the work that you all do with the College of Medicine, and obviously your many years doing this type of work as well as other work, what next steps do you think are needed to build institutional capacity around the work that you're doing it, and how it ties directly to our HSI serving designation?
Complete and utter silence. I honestly am having a hard time thinking of what else we could do, other than maybe going out into the community and creating other real life opportunities for our students. But truthfully, they get that experience in our standardized patients, in the clinical experiences that they have as well. I really am proud of the program that we have here at the College of Medicine. I think that, or I don't think, I know that many students tell us that this is what has drawn them to our institution as a place where they want to train to become physicians.
I'll jump in, and I think I'll echo what Dr. Valenzuela said. But I think as we think of the future, I think of this programming and building capacity not only with our students and faculty. I think always finding ways to find institutional sources to support our faculty who are leading this instruction, and continue to engage not only our medical and residents, but also, as Dr. Valenzuela said, the community. So, and I think advancing that is super important. So, continue to prioritize it in not only institutional support through leadership, but I think financial resources. I think one thing for our residents, we try to, in medical, I know for our residents, we try to support them in paying the exam as well. Yeah, I think just continue to find ways to help, and the reality, again, as I mentioned earlier, is our patient population, and making sure that we have that in mind, and how can we address these disparities, and really prepare physicians to provide that equitable care. And I think that aligns very well and advances our servingness as a HSI, is how do we prepare them to serve our community. So
Thank you both.
I'm gonna give you the kudos to the institution initiatives, having webinars like this one where we can share the work that we do. I'm not alone saying that sometimes we don't talk among departments. So having this out there, as you mentioned, YouTube, also sharing our contact information so we can collaborate and start building similar programs. As I mentioned, maybe not just Spanish, but any other language. So thank you so much for having this opportunity.
Thank you all. So as we come to a close, as always, just wanting to thank our three wonderful facilitators today for presenting on some of the work that they are doing. I know that I'm constantly impressed, and that's part of why I had reached out, just knowing all the work that you all are doing with not just your students, but also with the faculty and within the community. So I think you all are doing incredible work, and I think being able to share that out to folks is really important. So thank you all. I know y'all are also super busy folks. And so knowing that you were able to take some time to create this presentation and share with folks, I think is really special. So thank you to our facilitators today. Really appreciate you all. And as always, thank you to everyone who was able to join us. Again, this was recorded, will be posted on YouTube, and we'll be back next month on February 19th at 1 p.m. as always for our next webinar, where we're inviting folks both from the U of A and NAU to talk about cross collaboration around data collaboration with the tri-universities here in the state of Arizona. So again, thank you all for joining, and we will see you all later. Thank you, everyone.